Hi, and welcome to the American College of Sports Medicine Greater Regional New York Chapter podcast. I'm your host, James Jenkowitz, and today on our podcast, we have Thomas Hammett. Thomas is a doctor of physical therapy and the director of clinical services for Pinnacle Medical Wellness, a lifestyle medicine group based in the Seattle area. As the director of clinical services, Thomas provides consulting, training, and change management for clinicians and leaders in adopting lifestyle medicine practice. Thomas is board certified as a lifestyle medicine professional by the American College of Lifestyle Medicine, the ACLM. He serves as one of the founding members of the PTOT member interest group of the ACLM and is involved in multiple member groups for the American Physical Therapy Association. Thomas, welcome.
James, good to be here, man. Thanks for having me.
Oh, it's our pleasure. Thank you for taking the time and contributing to our podcast series. And yeah, so there's a lot of stuff we want to go over, Thomas. And do you prefer Tom or Thomas, or doesn't it make a difference?
I go by Thomas.
Okay, great. Okay, Thomas, then what we'll do then is I'm just going to reference you were part of our spring ACSM conference back in the spring, and you gave a wonderful presentation titled "A Case for Getting Therapists and Exercise Specialists on the Same Page," more or less, right? And it was interesting to listen to because it harkened back to an experience I had when I started as a personal trainer back in the early to mid 90s. And I was working for a high-end personal training studio in Bergen County, New Jersey. And they had actually paired with a organization that was well known in the physical therapy space at the time called Health South. And so what we did was, the organization I was working with partnered with them. So in the morning, me and one of the other trainers would go over to Health South and do what they called a type of post-rehab training. Right. So in other words, we would be talking to the therapists and they'd be like, okay, they just finished therapy for this cause. And they would give us, pretty detailed instructions, more focused on what we couldn't do. Right. So don't do this, don't do that. Right. But otherwise it's like, have at it with them. Right. And they really want to get better. And I thought it was a really interesting marriage of physical therapy and personal training early on. People are talking about this now, but, I did dabble in this some time ago. So your presentation focused on that quite a bit. So talk about that a little bit, talk about the state of where we are with that and your role and what you want to see as a physical therapist and how you want to integrate personal trainers and exercise specialists more into the fold and how you think the best way of doing that is.
Yeah, well, and thanks for sharing that story, James. I think, I love hearing about how in the past, and this isn't totally a new concept, right? I mean, for the past 10, 20 plus years, physical therapists have been pretty in tune to the idea that there's some limitations with what we are able to do in the time that we spend with our patients. And even maybe the specialty and the training that we get during PT school, where there's some benefit and value to bringing in a personal trainer. But I think, a lot of the people that we think of that would be, that traditional bridge over to fitness would be people that are interested in performance or who are already bought into this idea of exercise, maybe younger, more athletic people that are already exercising and who would be bought into the idea, if I make the recommendation to exercise when PT's over with a fitness professional, they're going to be the people that say, heck yeah, man, I'd love to learn more about that. What I know though, is that, the statistics today say that most of the people that I see in physical therapy are not those people that we're talking about traditionally doing that bridge to exercise. In fact, we know that over 2/3 of people do not regularly participate in any kind of exercise, and that about 6 in 10 people are in a state of chronic disease, meaning that that the conditions that I treat are chronic related, would benefit from a more active approach, a longer lasting active approach to care. And the lens that I look through to integrate fitness professionals into my care is that those are the people that if I'm able to, during my time with someone, get them bought into the fact that, the injury that they present to me with, or the pain that they're dealing with, might be part of a bigger issue that changing some lifestyle factors might help alleviate, that I'd be able to send that person to a fitness professional who'd be able to take the baton from me and develop some really awesome programming that would consider the fact that these people probably are dealing with some kind of condition that might limit their exercise, whether it's pain or high blood pressure or type 2 diabetes. So, there's tons of ways. I really think that a majority of my patients can and should be discharged into a fitness program. And a lot of my job is getting people bought into that and to believe that that the people that I hand them off to are people that they can trust, and that there's a value in spending time learning how to move their bodies and building a routine around exercise. So, that's a lot of my filter and my belief system around why PTs and fitness professionals should be talking more, and why I spend so much time, even in my presentation that I did at your guys' conference, introducing the idea of chronic disease and why it's so important for me to look through that lens.
Yeah. And you know what, before we actually go a little deeper into that, I noticed in your presentation, you gave a very brief history of physical therapy. And I'd like you just to sort of, brush over that a little bit. Like what is the history? How did this discipline even come into fruition?
Yeah. Great question. So, we as PTs, we're actually a little bit over 100 years old here in the United States. We're celebrating our centennial this year. The American Physical Therapy Association is. So, we really started as, there was a need during World War I to rehabilitate wounded soldiers, and there wasn't a medical specialty that was really suited to that. Nurses weren't the right people at the time. They had plenty of other stuff they needed to be doing by keeping people alive. So some kind of rehabilitation expert was needed to help get people that had been wounded, previously healthy people, to return to the maximal state of life that they could live once, the war was over, once they had dealt with their injury. And, as time developed, we stopped seeing people that were so much of this trauma-related type pain and injury, especially, and when I speak about our history, a lot of what I speak about is on the orthopedic side, or, the outpatient clinic that you might see driving down the street. And over time, as we developed, we really became seen as one of those groups of providers that helps people deal with orthopedic pain through movement, and help with musculoskeletal conditions like an ankle sprain or low back pain, or dealing with recovering from a surgery. And there's a certain population of people where they do look similar still today to that demographic of previously healthy people that are dealing with an acute injury. And when I say acute, I mean like you slipped off a curb and sprained your ankle, or you were playing soccer and you twisted and whoops, there goes an ACL. There's still a demographic of people who are previously healthy that come into our clinics and need a traditional rehabilitation experience. But many people that present to physical therapy right now aren't dealing with a acute injury from a previously healthy state. They're in a state where their bodies are more prone to injury and more prone to experiencing pain for any number of reasons. And I go through this slide that talks about those other factors that exist in the background. And, we as PTs, we're certainly getting better. There's a lot of new approaches, one being pain neuroscience education, but certainly some other approaches as PTs that we're getting better at not just looking at people as their acute injury, as a right shoulder pain, as a rotator cuff tear, or, as low back pain. But a lot of the lens that we still take in learning in PT schools is to see people in that way. And it misses so much of the contextual factors that go on in the background that may predispose people to injury, or predispose people to dealing with pain that is really something that should be dealt with without having to go through a medical encounter. So If I was to summarize the history that I talked through in the presentation, a lot of it is that. And for that reason, that's why PT needs to change and why we need to look at the bigger picture and think about how, beyond what happens in a, musculoskeletal biomechanical intervention that we do, what happens after that to really help people come to a longer term solution.
Right, because in World War I, as this discipline was just getting started, we didn't know anything about high blood pressure, diabetes, inflammation, right? So, and it's like these are some of the background things you were talking about before, right? Some of the things that might predispose somebody to injury that goes beyond the accidental slippage or the athletic injury, that kind of thing, right? So that said, you did cite some interesting stats in your presentation that speak to this. Right. So, for example, 12% of Americans are metabolically healthy. And that leaves a lot of people who are not metabolically healthy. So you're talking like over 80% of the population is metabolically unhealthy. Right. 6 in 10 have some kind of chronic disease or another. And that by 2030, 50% of Americans will have prediabetes or type 2 diabetes, which are both the result of lifestyle factors. So I assume these are the type of things that you were saying kind of build into what the modern physical therapists will have to contend with, correct?
Yeah, absolutely. And, those numbers are so hard to...
I know, to wrap your brain around.
Right? Yeah, they're so hard to believe and make tangible, but so early in practice for me, one of the things that our group is committed to doing here up in the Pacific Northwest is doing what we call a health risk assessment with our physical therapy clients, which, in physical therapy, it's common to take basic biometric values and basic health vitals is what we call them, right? So you take a blood pressure and a resting heart rate, maybe you do a waist to hip ratio kind of thing if you were really thinking in a preventative mindset in a physical therapy clinic. But what we do here in the Northwest is we commit to having a conversation with our patients about those health risk measures that we take. And one of those numbers that I always tripped up on was blood pressure, because I got desensitized to those ranges of 130 or 140. And I found myself saying to patients, this is actually pretty normal to have a blood pressure of 140 over 90. Go ahead and just keep an eye on that. And I had to check myself at one point because it's not normal, but so many of my patients coming in with orthopedic pain were in a state of high blood pressure that I even had become desensitized to it, that I hadn't seen a normal blood pressure in so long that I didn't even know how to talk about that anymore. So yeah, no, it is it's hard to understand and hard to think about that, those statistics that you listed, but certainly things that we need to be thinking about from the PT perspective, because it does influence our care.
And we've never had more information. We never had more resources. We never had more access to living a healthy lifestyle. And we like generation after generation, we keep going in the wrong direction, for the most part. But what I'd like you to do is even take that idea and take a deeper dive into what you presented in the presentation. You did a whole thing on how chronic inflammation, as a result specifically of excess adipose tissue, how that leads to muscle breakdown, collagen breakdown, tendon, cartilage, that kind of thing. That's really fascinating. And that's something that a lot of the people listening to this podcast may not be all that aware of. Remember, a lot of the people listening to the podcast are new to the ACSM. They're students going to school for this for the first time. So they may be, anywhere from a freshman to a senior, or just getting started in the industry. Right. So this is a whole new field. We've all heard about the term inflammation, right? And we know what it does to a certain extent in the gut. There are certain things we hear in the media about how it impacts you, but not a lot's told about the impact it has on the muscles, specifically in the cartilage and the tendons and ligaments. So can you expand on that a little bit?
Yeah, and first off, shout out to all the students that are listening to this ACSM podcast. If you're out there in college and already listening to this kind of stuff, good for you. But yeah, I'd love to briefly get into that too, and this is one of the things that even doctorate level providers have an incredibly challenging time doing, because, that thing that I was just talking about, that health risk assessment, if I'm sitting in front of someone with a rotator cuff tear and I'm trying to tell them why they need to make health changes. And, usually I wouldn't straight up tell them, hey, it's time, you got to make a change now. It's like a gun to your head situation. But really what it is we have to get some buy-in that it's connecting to the thing that they're there for. And what I need to do is show that these greater health measures that we're taking, that their blood pressure or their body composition actually do play an influence on their musculoskeletal system. And the way that I do that is by giving some basic education about, and in particular, body composition is a really tricky thing to talk about with people, especially people that aren't ready to hear it. And if I do get from a patient that they're ready to have the conversation about body composition and how it might affect the reason that they're there, what we'll talk about is that having an excess storage of energy in our bodies, having that extra adipose tissue, actually is acting as an endocrine system. It's creating inflammatory markers that lead to a couple of things. First, it leads directly to break. Yeah.
Sorry. Yeah, just back
That's
that up
great.
a little bit. Explain what you mean by that as its own endocrine system.
Yeah. So our adipose tissue isn't merely just the existence of fat. When our body collects excess, and it's important to note that every body has adipose tissue. Like, we all have a certain amount of body fat on our bodies. It's important that we do. If we didn't, we'd be in trouble. And it's possible to have too low of a percent body fat. There's a pretty happy range for people, and it would take way too long to go through the chart of healthy ranges of body composition for people verbally, so I'm not going to do that for you. But when we start to store an excess in adipose tissue, that tissue actually secretes inflammatory markers or secretes hormones that affect our entire body. So it's when we have a higher percent body fat, it's not just the presence of that tissue, but what that does. And what I think a lot of like physical therapists like to say, for example, or people that are thinking from a biomechanical standpoint, what they'll say is, that's when there's extra weight, for example, that's a lot of extra weight to put on a knee joint. And they'll talk about the physics of what's happening to a knee when there's an extra 20 or 40 or 50 pounds on that joint. But our knees are strong. They're meant to take weight, and they're actually meant to take quite a bit of weight. That's why we can lift so much and get stronger. But they're not meant to take it all the time, is part one. And part two is that there's other things that actually cause cartilage breakdown, the thing that we're really worried about in the knee joint, beyond just the extra weight. And it's really more of that inflammation that occurs as a result of excess adipose tissue. So does that answer your question? Does that make sense?
Yeah, it does. So in other words, when you say the knee is a very strong joint, structurally speaking, so when we do our squats, and you see some people could do a pistol squat, right? But you're talking about the damage comes when that extra weight is there long term, and you're walking on it all the time, and you're, going upstairs with all that extra weight, and it happens over a prolonged period of time where you're always carrying that extra weight. Is that correct?
To a degree, yes. What I think happens, though, is that we focus on that part of extra body weight a little bit too much. And I think that part of body composition or having a higher body weight is the only thing that leads to tissue breakdown from a musculoskeletal standpoint. When in reality, having excess adipose tissue is really problematic in a lot of different ways, and not just in that's extra weight on a knee joint kind of way. Does that make sense?
Yes, absolutely.
Yeah. Okay. Yeah. So those couple extra ways that I was talking about, I'll list a couple that I know just off the top of my head here. One is that, so our cells have this extracellular matrix, this collagen lining, and what regulates the buildup and breakdown, the repair and breakdown of those tissues, is dysregulated essentially when we have excess adipose tissue. Those hormone or inflammatory markers that I was mentioning lead to a breakdown in that process. And our extracellular matrices, or that collagen structure on the outside of our cells that help make them strong and resilient to breakdown, that process starts to become less efficient. And we get this weaker collagen lining around the outside of our cells as a result of this imbalance. So that's one specific way. I don't often talk to patients about that because there's not really a good way to say it without saying that, you know, our cells get weaker when we have these hormones in our body. But you know, the additional ways that when we have adipose tissue deposited in our muscle cells, so when we start to have enough excess adipose tissue that it is making its way into and between our muscle cells, what it does is the stem cells that hang out in there that are ready to become muscle cells, these satellite cells, they actually get differentiated into fat cells instead. So it's this process that only happens when we have muscle tissue embedded fat tissue embedded within the muscle tissue. But it ends up being another really important problem, that those muscle cells in waiting don't ever become muscles and instead start becoming fat.
That's crazy. Let's just walk that back a second and just kind of repeat that if you don't mind.
Sure.
So from the beginning, go ahead. I think that's an important part to really emphasize.
Yeah, absolutely. I'll try to start from whatever beginning I was at before, but I think most importantly that when we have excess adipose tissue that's hanging out in between our muscle cells, the muscle cells in waiting are stem cells, what we call satellite cells. They end up being created or turned into fat tissue instead of muscle tissue. And that's a really important thing, that the muscle cells in waiting aren't becoming muscle cells at all. And this isn't an all or nothing principle, obviously. Some of those satellite cells still get regenerated into muscle, but it's important to note that only happens in the presence of excess adipose tissue within the muscle cells. So just one of those additional important things, that if we can start contracting our skeletal muscle more often, if we can reduce the amount of adipose tissue that is in between our muscle cells, we can really improve how those muscle cells are regenerated and the strength of those cells as well, just by turning that process around.
So Thomas, is this more endemic in people who do not exercise or are not physically active? Am I correct? Or
yes, absolutely. Okay. Absolutely. And you know, this is why everybody says, you know, one short bout of exercise can turn things around, because one short bout of exercise, when our muscles start working the way that they're supposed to be, when physiologically we need to repair muscle tissue, because we did a workout that challenged our muscle tissue to the point that there's a little bit of breakdown, those stem cells immediately start differentiating into muscle tissue. And it's pretty amazing what our bodies can do with one bout of exercise and how quickly we can turn those processes around. Obviously consistency is better, which is why we need to keep exercising, but yes.
But you're saying the literature says that literally one bout of exercise can arrest that process and start turning that back into muscle instead of fat.
That's right.
Right. And specifically, you're talking about more high intensity exercise, or does that happen to the person who's maybe does a couple push-ups and then walks for 4 or 5 miles?
Yeah, that's it. You know, medical literature on this stuff is pretty hard to interpret in terms of what exactly the dosage is for that.
Mm-hmm. Right.
But yeah, I would say one bout of moderate intensity exercise, especially if these are people that have not been physically active leading up to that. So
that's very informative. I appreciate you giving us a lot of color on that. That's an important process.
You bet.
Important thing to make note of.
Yeah.
Let's talk about your relationship with the ACLM, the American College of Lifestyle Medicine. Let's talk about that a little bit, because that just came on my radar recently. I mean, I've been in the game for a while, but I wasn't that aware of that organization. But you've been involved with them for a while. So who are they? What do they do? When did they start? And talk a little bit about your relationship with them.
Yeah, so the American College of Lifestyle Medicine is actually a bit it's a bit older of an organization than I'd even known. They started in the late kind of 2000s, and so one of the things that I really appreciate about being a member in the American College of Lifestyle Medicine, I'm by trade a physical therapist, so I'm a member of many physical therapy related groups, some exercise groups. But it's pretty rare to see a member organization at the scale of the American College of Lifestyle Medicine that isn't tied to a specific profession. So one of the big benefits to me of being a part of this organization is that it's based around this idea of 6 pillars to living a healthier lifestyle, and really to prevent and treat chronic disease. So those 6 pillars being more physically active, focusing on nutrition, getting adequate amounts of sleep, reducing stress, having healthier relationships, and avoiding risky substances. And, I think this group, because of that being the foundation, brings in all kinds of different medical professionals from different walks of life. I think this year, or last year, the American College of Lifestyle Medicine's annual conference had like 37 different countries represented, and all kinds of different medical professionals. Certainly those included being fitness professionals or medical fitness professionals. So it's a really cool organization to be a part of, for the reason that, I'm so, by necessity in my work, focused on bringing together people in different professions, and learning how we can collaborate on what needs to be done to help turn around the chronic disease epidemic. So that really is the focus of what the American College of Lifestyle Medicine does. And they're, for that reason, growing super fast right now. So it's an exciting group to be in. And, certainly another one of my interests there is to figure out how, we as PTs can be a part of that movement, and how to insert ourselves into the chronic disease fight. So, yeah.
And yeah, that's wonderful they exist, right? Because prior to that, like I've had every certification under the sun, right? So you have the NSCA CSCS, which focuses on one part. You have NASM, which focuses on another part. I have a degree in nutrition and precision nutrition certified, which focuses on another part. So it's kind of nice to sort of have a governing agency that checks all the boxes.
Yeah, I agree.
And
sure.
So what do they go into each one with a significant amount of depth? And is it like a certification type of organization? Like what's involved once you become a part of that?
Yeah, great question. So I would say, if you're looking for depth, those, especially from a fitness perspective, those organizations like NASM and the ACSM are still, if you're thinking about an exercise related like certification, those are going to be the most in-depth things that you can do for yourself, is to get in with an organization like that, because the ACLM by nature is so broad, is targeted towards so many different medical professionals and so many different backgrounds and so many different lenses even, that it won't be as in depth for, say, someone who's going to be delivering exercise one-on-one, or who might be doing a nutrition counseling business as their career. I wouldn't recommend the ACLM certification being the end all be all of the training that you get by any means. But, one thing I will say about what that organization has done well, and what I think they really highlight in the certification process and just their general education, is the role that health behavior change plays in making lifestyle changes that are, the things that we would do to combat chronic disease, and teaching medical providers how to use techniques like motivational interviewing and coaching, and not just to be, those experts that sit on the pedestal and tell people what to do, And, for that reason, I think that group it really is super effective at getting medical professionals tied into, finding the value in what fitness professionals do, because it inherently gets us the ability, teaches us how to speak to people to get them to find the reasons why they might consider exercising when they haven't exercised before. So I think that is one of the big strengths about the ACLM, is that focus on behavior change and coaching, and something that I think a lot of medical curriculums, whether they cover it or not, don't cover it in good enough depth in training.
Right. So regardless of what you do, the ACLM would still be a good organization to be a part of, right? Because it sounds like no matter what you do, you could go to one place, a one-stop shop, and get a broad swath of information in the intersection of all these different disciplines to sort of serve as a support network for what you're doing, whether that be nutrition or personal training or physical therapy, et cetera. Do I have that correct?
Yeah, I think so. And, one of the things so I'm a part of a group, a member interest group, related to fitness and medicine. And, one of the big things that we're trying to get that group to promote right now is the role that strength training plays. And because I think, in being an organization that's targeted towards more of that broad stroke of members, it's easy to give that recommendation of 150 minutes of moderate intensity exercise and stop at exercise there. So educating those groups, the members of those groups, about the benefits of working with someone in a fitness role, and learning about strength training and adding that in, because there's less specific guidelines other than the 2 to 3 times a week that, we often hear. So, yeah.
Right. And that's why I was so excited to get behind the initiative of ACSM Exercises Medicine. Like I felt they really put the pieces together correctly. Just first of all, just defining it as medicine, I felt was a profound change. And I've seen the difference with my clients. Right. It's just like if you look at it medicinally, it's almost the same way that I tell them to take water now as a prescription. It's not a general thing just to say, hey, drink more water. It's like, no, you have to take this as if it were medicine. It's like you kind of have to do your walking or your exercising as though we're medicinal, because, well, it is medicinal. It's the best medicine you could possibly access. Right. So I found that started having more of a profound impact when I, as a trainer, nutritionist, was able to prescribe these things rather than, be general about them.
Yeah, for sure. And
that's where I feel like they got it wrong with the doctors, right? Because the doctors would be like, well, you need to exercise more. Okay, fine. Then you walk out of the office, you don't know where to go or what to do or what that means or how much or what intensity,
Exactly. And and you don't know what the person in front of you might already know or have tried about exercise.
Mm-hmm.
So and it takes time. I think that's why, when I talk about the benefits of having physical therapy as part of the plan, the medical plan, we really do serve as that bridge. And, I think that's getting overused as a term a little bit these days, but you may get 1 minute, 3 minutes, if you're lucky, to talk to a physician about movement, about moving your body. And that's it. And you may follow up with them in 6 to 12 months, and they may ask you about it again if you're lucky, but they may also have in their chart somewhere that we talked about it, and that's been addressed. And then we move on with life and talk about the other things that are going on. And, the benefit of physical therapy is that we inherently have people moving as part of our plan of care. But beyond that, we have the knowledge and, frankly, the buy-in to help people get down the road of seeing the benefits of exercise. And it takes time. It takes time to learn about that stuff. It takes time to learn about, what people have tried before and why they think exercise doesn't work and why they don't like sweating and, all these other things that people say that are their barriers to exercising, and getting that buy-in and teaching them who might be a good provider in the local area to work with them on exercise once PT's over. We just have such an opportunity to be, as a profession, as PTs, better than we are now, and to work together with fitness professionals to help make a difference there.
And that's even an obstacle to us as PTs and personal trainers as well, right? Because that sweating and exercising comes so natural to us. It's like brushing our teeth.
Right.
So you're working with somebody who doesn't do that. You know, it took me the better part of a decade to, you know, get that empathetic component. Like, what do you mean you don't enjoy doing this, right? It was like, that was a hard thing for me to wrap my brain around.
Right.
But because you're young, you're in your 20s, you don't know anything, right? But now it's, you know, it's a completely different animal now, right? I'm far more empathetic to it.
That's right.
So talk a little bit about your clinic. Where are you located? What do you do? What's your, you know, what's your goal in this whole industry? How would you like to see it take shape?
Great. Yeah, I'd love to share that. So, so the company that I work for is Pinnacle Medical Wellness. We're based just south of Seattle, kind of down at the foot of Mount Rainier, if you guys, any of the listeners have been out here. And, you know, it's a private practice. You know, we initially started as a pretty traditional orthopedic physical therapy group. But over the last 15 years, we've evolved quite a bit to being much more focused on developing a lifestyle medicine focus, a truly collaborative approach between a group of providers that live kind of in that post-primary care, or, you know, as PTs are kind of moving in some ways a little bit into a primary care space, from that area down to what you would traditionally consider to be maybe like outside of medicine type professions, the fitness professionals and even nutrition counseling, which I think is, you know, certainly has an important role within medicine, but outpatient nutrition and seeing a nutritionist may have been kind of seen as this outpatient industry on its own almost. So what we do here is, you know, we see people that are dealing with traditional medical issues and help connect them with the resources that they need to learn about the value of their bodies again, and learn about the approaches that they can take, the little steps that they can take to start to address the goals that they have for themselves. And, you know, in physical therapy, a lot of times that starts the same way as it would in any other PT approach. People are hurting, or they're dealing with something that they've been dealing with for a long period of time. And we work through getting their bodies moving again. But that idea doesn't stop at the end of the plan of care with us. You know, for me, what I care a lot about is, this is a personal Thomas thing, is, you know, I want to see my profession move more and more and more towards that idea that we're not seeing people for an isolated plan of care that ends after, you know, 6 weeks and 12 visits, and finishes with a home exercise plan that never gets progressed, and is a piece of paper that gets shoved under the nightstand and never opened again until that body part starts to hurt again. But beyond that too, that I want to see medicine start to move more and more towards that preventive approach. And, you know, I do think in the next several years here, we're going to see some pretty big changes in healthcare that, whether it happens from internal sources or externally, are going to move medicine in that direction. So I'm really passionate about getting our groups, our providers, to be ready for that and to practice in that way, because I think it's what people truly want when they sit down with a medical provider. And yeah, it takes a change in the lens. It takes a change in your mindset as a medical professional. And to me, I think that's just a really great challenge to show up to work to help get our medical providers there and to serve our patients in the ways that they truly need it. So,
and I think one of the upsides to the last horrific year we had in 2020 with COVID is that it did kind of make people question, you know, the current medical paradigm and how we see it. So I would imagine changes in terms of how people are going to be pursuing their health and looking at it are going to be different going forward in this post-pandemic world, because people have had, you know, they've really had to take inventory of their health in a way they haven't really been forced to in the past, right? Because in the beginning we didn't know much about this condition, so it was like, well, am I healthy? Do I have a comorbidity? You know, am I at risk for actually getting this thing? Right. So I think it brought a lot of awareness to people and how they see their bodies and how they look at their health. And I think that's going to create a change going forward.
Yeah, I totally agree. You know, so up here in the Northwest, we were pretty dang shut down, and I know that you guys out in the greater New York area were dealing with a pretty similar thing to start out with. And you know, there was this really interesting phenomenon where I spent a lot of time driving during that period of time, and there was no one out, so I knew you know, most people are staying in their homes. But then all of a sudden there were a lot of people running. And I had never seen that many people out on the street or on the sidewalks, wherever I was going, just running. And I thought, you know, this is going to be a really interesting case study on how people who haven't maybe tried exercising at home before end up dealing with maybe new pain or injuries, but also, you know, maybe how health swings during this period of time. And I think, unfortunately, because of isolation and lack of resources, most people have been in a worse state of health as a result of COVID than in a better state of health. But yeah, just kind of an interesting period of time. I'm really I'm looking forward to seeing what the data says about how COVID affected our health and what we can learn from that.
Yeah, and to see how that may or may not, but I think it's going to, how it's going to impact the industry as a whole, you know, going forward. So that all remains to be seen. But I agree, like that was another one of the upsides. I was on the road quite a bit in the beginning too, and I'm like, wow, this is I'm not complaining about the empty highways like that. I'm okay with that. Sure. That was kind of nice, as short-lived as it was. But all right, Thomas, well, thank you so much for your time. If people want to reach out to you or your organization, how can they get in touch with you?
Yeah, great question. So I'll give you a couple of resources. I'm on LinkedIn. My name's Thomas Hammett. I'm the one that works at Pinnacle Medical Wellness, if there happens to be two. I also would love to point you guys just towards our website for Pinnacle. It's pinnacle-pt.com. Just gives a little bit of information about who we are as a company, our mission of transforming medicine to end chronic disease, and a little bit about what we do up here where we work and the groups that we work with. So yeah, obviously, I think my contact information's on there. So if you want to reach out to me, you can, but that's what I have for you.
Great. And are there any other things you'd like to mention that's no longer a question of mine? Just any other thoughts you'd like to leave the audience with?
No, you know, I love speaking to students, and if you're someone who's thinking about coming out into, you know, from your undergraduate studies and working in a fitness field, one, I want to tell you that it's incredibly important work. There's a lot of people out there that want to become physical therapists or want to take their fitness career and do something else with it. But if you can find a good fitness position or find a way to make your own business out of being a fitness professional, it is incredibly important work. And there are PTs and other medical professionals out there that are dying to work with good people that know what we talked about today, which is that most of the clients that I see are needing to move their bodies more and just learn the basics about exercise, so that they can live a healthier life and really take their lives back into their own hands. And if any of you are considering or thinking about moving on, I hope that message maybe inspires some hope or different thought about the importance of a medical fitness career, because I just can't state enough how important those careers are in our medical system and how important they will be moving forward, even if they're a little hard to find right now. So I think that's the last thing I want to mention, James.
Yeah, no, I think that sums it up great. And I like using that term, medical fitness. I think it's so much more inclusive. I think it's so much more intriguing. I think it's so much more attractive, you know, than just saying medicine or fitness as separate entities. You know, they really, that term really, you know, forces you to understand the relationship between the two. So
Absolutely. Yeah, I didn't create that term. There is a medical fitness association if you're interested in looking into them as well. But I agree, it's good language to use and an important track that I think a lot of people in fitness tracks in school aren't thinking is something that exists. I was talking to friends, actually my co-presenter at the conference that I did for ACSM, Jeff Young, and he was telling me that 75% of people that exercise on a regular basis aren't exercising for performance. So they're people that are trying to get healthier or doing it just to stay healthy. They don't have goals of climbing mountains or playing sports. And, I think a lot of people that start out in the fitness related track think that they're going to be working with athletes. But there's so many other people that are interested in exercising and staying fit. There's so many people that can learn more about the value of their physical health and what movement can do. And again, I just can't emphasize enough how important those careers are. So I hope that means something to somebody and that we get some good medical professionals moving forward into the future of medicine.
yeah, and that's a great caveat because you may get some athletes, you even may get one or two top athletes, right? But that pick is very rare, and it's not going to be the majority of your work. So just go into it knowing that the majority of your work is going to be working with, the non-athlete who's just trying to, move better, play with their kids without injury, move their groceries and that kind of thing, right? Which is a task in and of itself, right? So, Thomas, thank you so much for your time. I really appreciate it. And we have your contact information, so if anybody needs to get in touch with you, it's right there on the screen. And we'll do this again in the future sometime.
That sounds great to me, man. Thanks, James. I really appreciate your time and having me on your show.
Oh, it's been a pleasure. Thank you so much, Thomas.